Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. Jon Bloom, CEO and co-founder of Podimetrics. Jon, welcome to the show.
Thrilled to be here this morning.
So, Jon, what I always like to do before getting into the main part of the conversation is give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Jon, the floor is yours.
Well, Jon Bloom, and after a stint as a terrible musician, and then as a short span as an anesthesiologist, I'm now focused on diabetic feet as part of Podimetrics. And we start off as a med tech company, and we've changed over time to be much more now as a holistic services company, trying to make sure that we can care for this patient and keep them out of the hospital system. But yeah, it's been a 13-year run now in Podimetrics, and it still feels like in many ways it's still day one.
That sounds great. Kind of before getting into what you view as holistic care, what I always like to ask first-time guests is, what first got you into healthcare, especially as you said, you went from being a musician into healthcare. So that's a pretty significant transition, although maybe one that's not necessarily as surprising. It's I remember one of my wife's med school classmates was a part-time musician on the side as well. So it's there seems to be overlap there.
Well, I was it was punk music back then. Like we thought we were very hip and very against the establishment, and I loved the music scene very much so. But I fell in love with medicine. I used to work at a 1-hour photo lab at Costco ages ago, and one of the people that I got to know, she was the wife of a cardiothoracic surgeon. And one day she said, "Hey, do you want to meet my husband? Maybe get a chance to see what he does." And I was thrilled. So I felt within like a week, I'm scrubbed in a case. I'm not, clearly I'm not supposed to touch anything, but I'm just remarkable to see how we look, underneath the covers, underneath the skin, and to see what does smoking do to the lungs. Like you see, like these are no longer pink lungs, and to see, the effects of atherosclerosis on this patient, to get to meet the patients and how it was impacting their life. It was like a lightning bolt. And so I'm like, I have to figure out how to be a physician. But at the time I was actually, I'd been at school for a bit. I had a lot of work to do to try to build up my application. But yeah, it was just this one wonderful human who introduced me to the care that he provided, and that was the hook. Oh my gosh.
Yeah, so that's amazing. So it's kind of then how'd you go from direct patient care into I think as you said, kind of the initial tech forward and now holistic care Podimetrics.
Well, okay, so now fast forward way in advance. Now I'm an anesthesia resident at Mass General, and one of my attendings was the chief medical officer at the time of Covidian. They have a massive division looking at monitoring systems and airway and ventilation. And technically, I had applied to business school, but I didn't know what I was going to do after residency. I thought I was going to go into surgical ICU fellowship. And instead, he convinced me that maybe I should do a fellowship in technology instead of going into the clinical fellowship. Just give him a year, move out to Boulder, Colorado, and learn a lot about the technology. And as a medical doctor, think about what cool technologies out there that we should be thinking about, or working with R&D teams to make sure we're going in the right directions, or even helping sales. I just thought it was such an interesting, rare opportunity that I may not get again. So at the time, I thought it was just going to be like, a 1-year fellowship. Jumped over, moved to Boulder, and then man, hook number 2. I was hooked. That was an unbelievable, not just helping one patient at a time, but now the potential for whole populations at a time. It was that still doesn't get me to where Podimetrics starts, but at least that's the initial hook to get into what tech can do.
Yeah, and I think that's as you said, the ability to impact so many different people. So and connected to that, one of the things you were describing about Podimetrics is that, it's diabetes focused, but now you're looking at holistic care. So how did that evolution kind of take place? And, from your perspective, what does holistic care really mean?
Yeah. I think in some ways, I'll use the word victim, but we fell victim to it too. It's so easy for us to say we're just a diabetic foot company. I recognize, even as I did my intro, I'm so used to even saying that. And language is powerful. And really, we recognize that there's a whole patience that's there. And tech itself can sometimes have a very limited impact. It's often a relationship that moves the needle. So we really had to recognize that there's so much going on in this patient's life. Whether we think about the social determinants of health, whether we think about inflation, all the things happening today, it was a recognition as we built our company that if we really wanted to make an impact in this patient's life and to affect the populations most at risk, we had to take in the whole patient and recognize there are so many things that our patient is having to struggle with on a 24/7 basis.
So that sounds like it's bringing in a lot of different factors. And, obviously you referenced SDOH, which has been a hot kind of buzzword within healthcare for a few years now. But what were some of the challenges and, kind of hurdles that you had to overcome as you started to build out a process or means of engaging a patient across all those kind of factors and pieces of their lives?
Yeah, I think, I started seeing this even when I was at Covidian. If patients can't use a system and make it part of their daily life, it's useless. It has no impact. So I think we really had to figure out how to build systems that can fit into patients' lives. And I think that was a big focus for our development, was just, starting with usability. And as far as even some of the biases I think we have in the healthcare system. When I trained, we would often call the patient we'd label them as the poorly compliant patient. I remember that is just like, well, one of the things I'm trying to communicate to the clinician is, well, they're just not taking the medications and the things, not recognizing that often they can't afford that medication. They can't get the transportation to pick up the medication. They may not even be able to get to me, or worse, maybe they're right in front of me now, and I'm using language that is not approachable. I talk about, just, I think we still have we had to learn both as a healthcare system and certainly in our company to try to find ways to bridge gaps in access, far beyond just some of the gaps that we talk about today.
And as you're thinking about bridging those gaps, I think you said you are focusing on some populations that are maybe traditionally underserved or maybe particularly challenging. So how did you start bridging those gaps and building those bridges to, address, maybe not address, but at least acknowledge and figure out how to factor the hindrances that they're encountering in their lives to support them in being able to access the care?
It's a great question, and just to sort of zoom out for a second, I'll talk about how we bridge the gaps. What Podimetrics does is we're trying to help patients who are at risk of diabetic foot complications, but try to keep them out of the hospital, out of the clinic as much as possible. We use tech, we use data science, and we use a team of nurses to try to, again, make sure that it's a relationship armed with really good data, because I believe that that's what moves the needle. And I think we had a lot of work to do in the beginning to figure out how to do this, speaking to how do we bridge those gaps. And we had to recognize that this patient is often in the home, but doesn't have easy access to get to me. So can we bring the care to them? When we think about designing of technologies, we have to make sure that the tech can hopefully work in any home. So as you think about gaps in tech literacy, make sure that it's super simple, that there's no, that you don't need to know, how, ideally one button, power, maybe we have volume buttons, make it super simple and approachable. We think about health literacy. How do we make sure we're talking about the problem and how we work in ways that's approachable to everyone? As we think about workflow, how can we build it so that it's integrates into a life that's often so complex, has so many things that this patient has to care for, well beyond just healthcare, right? This is it's a very, especially when you think about our Medicaid population. So we had to think about design across all these elements, and then we have to continue to think about support, ongoing support. So what design is one piece, but how do we continue to support this population so that it is super easy to use, super approachable, and in the moment that they need care, that we can bring that to them.
So you just mentioned that doing that within the Medicaid population. So were there particular, kind of difficulties in pursuing that population? Because feel that oftentimes it's, you hear that maybe reimbursement or, financial resources are, not as available in Medicaid, and that can, keep people away from wanting to tackle that population and drive positive benefit and change. So it's, kind of how did you factor that in and then, become successful in an area where, as I said, a lot of people seem to want to stay away from it?
Well, would love to talk about like just some of the challenges that are here that we have to be so mindful of. But I'll start with like the why. We started actually in the VA, where almost every investor told us, don't go to the VA, right? They all had a boneyard of companies that they had invested in that had just gone bust. And so it was kryptonite when we said to go to the VA, but we wanted to go there because, well, first of all, I grew up in the home of a Vietnam veteran, and I grew up more or less in the VA, and it was just this empathy that I had, understanding what they went through, the alarmingly high rate of diabetes, the high rates of amputation. It was just an important population to care for. Now, as we think about Medicaid, similarly, like we want to go to where the real struggles are, and often that's in environments. I think about Jackson, Mississippi. I think about states with very limited infrastructure. Here's where we have to solve the problem, not necessarily in a perfectly urban environment where everyone can just hop on a quick bus to get even to anywhere. Like, can we solve it for there? So that's the why. Now, Medicaid is hard. And maybe it's really hard, as was the VA. But I think it's important for us to go to where the biggest challenges are, if we're really going to try to make an impact in U.S. healthcare system, or of course even outside the United States.
And as you were pursuing those challenges, was there one particular challenge or kind of set of challenges that you were surprised to encounter that maybe went against some of the assumptions you might have gone in with?
Yeah, it's interesting. Even coming from a medical background, I don't think I fully appreciated just some of the burden that this patient can go through. We actually did, and I think we're still trying to understand it as a healthcare system. And we just did a recent survey among Medicaid beneficiaries with diabetes, support with Pure Spectrum, trying to just better understand some of the challenges that they may have, whether it's to their physical health, but mental health, access to technologies and systems that could be beneficial, educational support. A couple just data points that jumped out at me as we just get better at understanding how health can impact our life. One was that among Medicaid beneficiaries with diabetes, 2/3 of these patients are actually living with behavioral health issues on top of what they would normally, typical medical challenges they have. In terms of just access to technology that creates better access, hopefully keeps them healthy in their neighborhood, in their home. Only 84% saw the value of these systems, but unfortunately, 79% said that they didn't even have access to systems like this. So they got it, but they couldn't get access to these technologies, and that they felt that half of them said that even if they did have technology, or the technologies they were aware of, very few of them had clinical support around them. Yet again, if we give just cold tech out alone, it's hard to really move the needle there. A couple of last points that came out of the survey, because I just find it fascinating. 42% talked about not being able to get to the medications they need because of affordability issues. So yet again, when I was a clinician, we just took that for granted that I would write for this medication, just presume they could take it. 35% talked about an inflation affecting their ability to get medications. 54% said they couldn't afford healthy food options. Yet again, something we might just presume or take for granted, that I can easily get to a grocery store for healthy fruits and vegetables. And then 1/3 of them reported lacking reliable transportation to even see their providers. So here we have a population that has, of course, we recognize the physical complexity. If you have a diabetic foot risk, you typically have compromised cardiac function, pulmonary function. Yet we think about the mental health on top of it. And then again, social determinants. It's if we're going to really move the needle here, we have to do far more than offer just tech, right? We have to wrap around it a support system.
Yeah, and those are great points, because it seems like a lot of those kind of issues that the survey revealed, they wouldn't impact just your health, but they're impacting daily life and daily living, and a lot of different interconnected factors there. And for those of you just joining, I'm talking with Dr. Jon Bloom from Podimetrics, and kind of talking about working with non-traditional populations, or populations that wouldn't necessarily get the right or enough focus historically. And John, you're kind of just going in the direction of talking about like the mental health challenges. So it definitely feels like there is greater recognition and awareness, and maybe the removal of some stigma that, I think to the point you were making, you can't treat just physical health. It's physical and mental are combined. And now we're starting to see movement in that direction. So kind of where have you seen your efforts going when it comes to kind of combining those two approaches? And, and kind of following up on some of the other things, are what are some of the challenges that you've kind of encountered and then started to overcome as you're kind of recognizing the role of mental health and starting to incorporate support in that direction?
Well, certainly, yeah, the impact of mental health can be quite profound. I think a lot of this time, this patient feels that they've just been in and out of the healthcare system. They've almost lost agency in some ways, control over their life. And I think everyone in the healthcare system, all of us should be on the lookout for mental health challenges, because they make everything so much more difficult. You might lose interest we'll use that phrase in medicine, but it might create additional challenges to get to healthy foods. It might create additional challenges to get the medications you need. And so we all have to play a role there. It's so important. And when I really recognized just how big of a challenge this was, I remember hearing about a patient, this is a few years ago now, where they suddenly stopped using the system. Per protocol, we'll call them, just make sure everything's okay. In this case, we had to leave a voicemail, not uncommon. And the next day, they called us back. And on that call, they, of course, thanked us for our time. And he acknowledged that the pain in his limb had become so severe that he had decided to take his life. He wanted, again, to thank us. And, of course, in that moment, that's what we got to make sure everyone is trained on how to handle that. So in this case, we were able to get him the support he needed. He's still with us, but you can imagine how that went through. But as I stood back to think about that case, he didn't tell that to his son, who did everything for him. He didn't share that with his provider, his physicians, that this was the case, not the nurse nor even the care manager within the health plan that was trying to care for him. And he told us this. And thankfully, in that moment, we were able to get him the care and support that he needed. And I just think about that a lot. Everyone has to play this role. You never know if you're going to be that person who gets to be, hopefully, the supporting other end of that phone call. And in this case, we have to, even as a tech company, we have to do a great job of making sure that we have good mental health, good support there, so that they can manage the life that they want to live.
Yeah, and on that front, is there a particular method or approach where you encourage the patients you're working with to talk with you about their mental health, concerns or struggles?
Often it's just, you just keep a caring ear out. You're looking for this. If this patient they're presenting very differently, it prompts a couple key questions. And I think for our clinical team, it just helps to hire aggressively for super curious and super empathetic people. They just want to understand. They want to help improve. And I think that's been a key, just making sure we're getting, wonderful clinical staff and this appreciation that there's a whole patient that's here. So make sure that we ask questions and understand how they're doing.
Yeah, and that seems like it kind of goes back to one of the points you made in terms of like the different components you bring together for your service, which is a personal connection and actually talking and listening to folks. So it sounds like that also makes a difference, where if you're just actually connecting with them and establishing a relationship, then it can grow from there.
Yeah, you got to make it super simple to use in terms of our, the hardware piece. That's got to be easy to use. You got to make sure that it's easy to onboard this patient. And that it's as passive as possible, and that allows for us to really start to, hopefully, as effortless as we can, to build a trusting relationship. We've got your back. We're trying to understand, hopefully find issues before they happen, and give us a chance to give you support the moment that you need it, whether we're immediately aware of it or not. That there could be something, for example, in the foot, that could be a potential wound that's coming. Can we, in those very moments, bring the support to you to try to prevent a bad outcome from occurring.
Yeah, so to me, as you're describing it, that then just goes back to what you were talking about earlier, which is it's all about holistic care and treating people as an entire person, because it's easy to try and focus in on one particular issue and say, oh, I can solve that, but then you're missing so many other pieces that are probably feeding into it and are interconnected, and you might think you've solved something, but you've really just kind of put a Band-Aid over the deeper problem.
It's true. Yeah, that's exactly true. One of our peer-reviewed pilots. Often we'll just run the pilot with a paper, and this one, or with a pair. And this one we wrote it up. One of the key numbers that was affected is we dropped all-cause hospitalizations across the board by 52%. And then we get asked, what DRGs were coming down, meaning the types of hospitalization. Excuse me, I still speak with terrible jargon, which it's always an effort to make sure we're not doing that. But just under half the hospitalizations, no surprise, were diabetic foot related. But 52%, the top 4 reasons for hospitalization were things like myocardial infarction, heart attacks, stroke, heart failure exacerbations, COPD exacerbations. Those were the top 4. And you realize that once you have this patient, you're delivering good care, you can look out for a number of complications before they happen. We're just trying to make sure we get them the support they need before they need it. Really when it's needed, and try to allow them to stay out, to not need to see me in the clinic or in the operating room.
So kind of that information then probably leads me into another area that seems to always be a popular issue within healthcare, which is if you're seeing that broad base of an impact, are you then pushing into value-based care, where kind of implicitly what you're saying is you're creating better quality, better outcomes. So kind of where have you seen pushes in that direction, and where have you been involved kind of on the value-based front?
Well, first, and just even think about clinical endpoints. So what's most important for ideally having a high quality system is we want to limit the need for healthcare resources to be used. So main metrics we look at, reduction in all-cause hospitalization, reductions in ED visits. In that same study, we dropped ED visits by 40%. Outpatient visits, and that one we dropped it by 26%. So we're trying to show that good early identification and intervention can reduce the expensive use of hopefully unnecessary healthcare resources. And that way, then we play really well with value-based care. But of course, what we can start to do then, as we work with insurance companies, is we can lean into risk. The idea that, okay, well, great, like let's align we work by creating savings, and we can take a part of that savings back as our revenue. I think risk is this amazing instrument to really align incentives all the way across, from the patient to the provider to the health, the payer itself. And so I think value-based care has been this unbelievable change. I mean, it's been here for ages. California had been doing HMOs since I feel like the 80s and such. But it has allowed companies, even medtech companies, to find new ways into homes where everyone is aligned. We're trying to keep patients out of the healthcare system, and we can create a sustainable business through actually creating significant savings to the healthcare system, instead of charging a whole bunch for a system to try to add extra cost to what is already, frankly, a reasonably bloated healthcare system.
And kind of as you're recognizing and seeing those interactions, how did that then influence and evolve how you were approaching patient care and identifying how you wanted to work with patients?
Well, in the beginning, I kept hearing the phrase, John, prevention doesn't pay. This is coming from folks who can finance healthcare, who had concerns. Here's a prevention company. In a fee-for-service environment, you get paid for the hospitalization. Prevention doesn't pay. There's no reimbursement for it. And well, certainly the system had to exist. Here's a patient who's, I could spend whole days in the operating room doing amputations. Or this patient's, I remember Atul Gawande would talk about the hot spotter patient. This patient was constantly in a healthcare system. We have to do good preventative care. And we realized that you could build that system by working with the payers and with the providers, and especially we started in integrated environments where they were kind of the same at Kaiser Permanente, where they have both sides. I think that was the key piece to sort of jumping into it. There was no other ways. There's no way for us to exist. there's no way for a system to be there in a typical fee-for-service environment, but by working with these payers and these integrated delivery systems, it got us into the system, and then we could build the data sets that we needed to expand far beyond it.
Yeah, and I think you raised a really key point there, which is you had to overcome that mindset of prevention doesn't pay, as you said, because it's a really cynical statement to some degree, because it's as you were describing, you could see this impact, but then the unfortunate financial side of it was you might be creating great outcomes and doing improving people's lives, but then how are you going to get paid? So to me, that almost suggests the need for a fundamental realignment of how the system is structured.
Yep. I mean, we're doing better as we think about moving Medicare to Medicare Advantage. Where now you have basically, there are some don't get me wrong. There's always challenges that are cited with a managed Medicare environment, but it meant that now the payers do well by having the best possible outcomes instead of limiting their spend as much as possible, right? That might give a patient a complication that they have to pay for. Now they're suddenly incentivized to give her the right preventative care. So just to me that has been a big help with Medicare Advantage, and I feel that hopefully more and more fee-for-service moves over to these capitated models where now ideally, again, the system is aligned. The system benefits now from the best possible outcomes, not benefits from the most possible services rendered. You can see right now my face is almost like wrinkling up here. Some of the bad incentives that can be out there. Not that the healthcare system is doing evil work in any way, but it is good to have alignment of incentives. It does make a difference.
No, I think you're definitely right. It's that kind of that align the incentives better. And John, as I said, believe it or not, we are out of time. So I want to thank you for those great parting thoughts and for a great conversation today.
Thank you again so much for having me, Matt. I appreciate it.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.